A very good evening to all my dear MOS members and the ophthalmic fraternity who have joined today. This is a very interesting webinar which I decided. We have the MOS academic committee in which we have decided to have preferred clinical patterns or preferred clinical practices that we have in India. And today we have an expert faculty. We have Dr. Akshay Nair, a renowned oculoplastic surgeon from Bombay, Dr. Tarjani Deve, the associate head of the LBPI, and we have Dr. Namrata Arulkar. She is also an renowned oculoplastic surgeon practicing in Pune. We have our moderator also today, Dr. Prerna Tahiliani. She's a little busy, so I request Dr. Namrata to take over the session till she joins. In the meantime, we are going to have the topics today well covered is regarding evisceration and enucleation. What are the preferred clinical practices by both our speakers, Dr. Akshay Nair and Dr. Tarjani Dave. Both of them are very good friends of mine. Tarjani is a daughter of my close friend, Dr. Yogesh Shah, the Papa Secretary, General Secretary of AIOS. So I am so grateful to each one of them. On a short notice, they have agreed to be part of this. And I plan to have a booklet coming out the way the AIOS ARC usually gets on preferred practice patterns. The latest one being one of the endophthalmitis. So similar pattern, we would like to have it in Maharashtra. This is the first time a state has taken over such a topic, and on various subspecialties, we are going to have the sessions on a regular basis till my tenure comes to an end. So over to you, Dr. Namrata, to introduce Dr. Tarjani Dave and Akshay Nair before they start the session. Wish you all the best and happy viewing, everybody. Yeah, Dr. Namrata.
A very good evening, everyone. Can you hear me?
Yes. Loud and clear. Very good.
A very good evening, everyone. And it's a pleasure to have expert faculty like Dr. Akshay Nair and Dr. Tarjani Dave with us today. I will like to start with introducing my friend Akshay. Akshay is a postgraduate from Shankar Netralaya, and followed by that he did his fellowship at Elli Prasad Eye Institute, Hyderabad. He was also trained at New York Eye and Ear Infirmary, USA. His areas of interest are eyelid and ocular surface tumors, periocular aesthetics, endoscopic lacrimal surgeries, and he has a penchant for teaching postgraduates. He has more than 100 papers published in peer-reviewed journals and written, and he's a reviewer for multiple journals. Over to you, Akshay, for your enlightening talk.
Thank you. I'll share my screen.
Yeah. Namrata need to stop share. I think she has done it.
Yeah. Already. Can we have everybody else on mute? Then I can. Thank you so much. I think in many ways it feels so good to be introduced by someone whom I've known for as long as I've been an ophthalmologist, or even before. Namrata was a senior and then a colleague of mine in training, and we go back a long way. Thank you so much for that kind introduction. I'll be talking about enucleation, what, when, and how. And given that we are looking to set the practice patterns or explain what is the gold standard when it comes to the practice of this surgery, we'll be sticking to the basics. So enucleation serves two purposes. One is rehabilitation, where we take care of a painful blind eye in which there could have been multiple trauma, there could have been multiple surgeries, infections. It could be a thusical or a pre-thusical eye, or it could be a staphylomatous eye. In these cases, when we talk about a blind eye and we are doing a cosmetic rehabilitation, the indication for an enucleation is different as compared to that of an intraocular tumor, which continues to be the most common indication for an enucleation surgery. So the aim is to treat the pathology. If it is a tumor, an intraocular tumor, the aim of doing an enucleation is that surgically, in a single step, the patient is tumor free. Say, for example, group D or group E retinoblastoma without any optic nerve extension or any histopathological risk factors in a single isolated unilateral retinoblastoma, which is advanced, and enucleation is virtually curative. The other indication, like I mentioned, is rehabilitative or relief from pain. And while we do this, by putting in an implant, we are maximizing the orbital volume or replacing the orbital volume, which is lost because of the globe being taken out. And by providing a prosthesis, we are improving the quality of life and giving good cosmesis, because that with a mobile prosthesis, the patient is able to get back to daily, daily tasks and their lifestyle as they were before. And as is the case with every surgery, the aim is to reduce any other complication that may arise. There are different techniques for enucleation, which depend on the indication for surgery, variations in techniques, which can also be depending on the type of implant that is used. Now, this is a table which, like since as Dr. Jigne said, that this is the, we are looking to create a preferred practice patterns, or at least give a trend of what is the practice that is happening. In that sense, this table is a very important one, which tells us the indications and contraindications for an enucleation versus an evisceration. I'm sure Dr. Tarjini will talk about evisceration, but from my perspective, when we talk about an enucleation, it is extremely important to know that in an intraocular malignancy, and evisceration is an absolute contraindication. So when you have a intraocular malignancy, it is most likely that you will do an enucleation. But the question is, if you have any doubt that the eye could harbor an intraocular tumor, in these cases, you should not want to do an evisceration at all. Say maybe a child who's given you a history of multiple episodes of congestion, redness, and now has come back with a thusical eye in a matter of few months or weeks. Remember that even retinoblastoma can be seen in thusical eyes, which is why a thorough examination is absolutely needed. Similarly is the case for panophthalmitis, where all the three coats, the entire eyeball itself is infected with all three coats, the retina, the choroid, and the sclera being infective. In this case, an enucleation is considered a contraindication, because by cutting the optic nerve, you are potentially opening up the dura, which cover the optic nerve sheath, which could be a track for possible extension of the orbital inflammation or infection into the brain. This is theoretically possible, which is why it is considered to be a contraindication, panophthalmitis. And another thing is small thusical eye. In these cases, an evisceration in extremely small or extremely thusical eyes may not be possible, where again an enucleation is preferred. Other cases like a staphylomatous eye, a pseudo eye with an opaque cornea, endophthalmitis, or multiple penetrating trauma, or a silicon eye filled eye, an absolute glaucoma eye. In these conditions, an enucleation or an evisceration can be interchangeably done depending on the comfort of the surgeon. But these three indications are, more or less extremely important. Again, from a general ophthalmologist or a trainee perspective, the requirements before, this is virtually like a checklist that I keep in mind before going in for surgery. Preoperative examination has to be done again on the day of surgery. In fact, if it is a retinoblastoma or an intraocular tumor, both eyes are dilated and examined on the table under anesthesia. And of course, you take a timeout and announce to the entire operating team which eye would be operated, and the other eye has to be patched by the operating surgeon himself or herself. Preoperative examination is important. Counseling. Remember, enucleation or evisceration is like an amputation. You're losing a limb, you're losing an organ, you're losing a body part which was your own. So counseling and letting this fact sink into the patient and the relatives is extremely important, which is why it's good to use photos of patients who've gone through this journey before and after, videos of patients with prosthetic eyes, showing them the implant, how it looks like, how the conformer looks like, how a prosthesis looks like, having them feel it in their hand, in the OPD before you plan surgery also helps in a long way in patients coming to terms earlier and better. Give them a timeline of the procedure, tell them how long the duration will be, how long the recovery will be, at what time do you put in a prosthesis, and by when do you expect everything to have settled down. In cases of tumors such as retinoblastomas, melanomas, meduloepitheliomas, and other intraocular tumors for which you are enucleating, you need to tell the patient that while surgery in most cases is the end of treatment, but actively you need to follow up the patient, especially in retinoblastoma. If there are risk factors, then the patient not only needs to follow up for chemotherapy, but also for examination under anesthesia, for periodic checkups of the other eye as well. And at the end of the day, before the patient is signed off, the in an enucleation, before the consent is given to the patient, the surgery has to be endorsed by at least 2 trained ophthalmologists. Remember, a trainee ophthalmologist or a person who is not yet been board qualified or has a diploma or a master's or a DNB, he is not an ophthalmologist. So you need a qualified ophthalmologist to agree on your diagnosis and management of plan. A B scan pre-op, I do it for every patient, whoever undergoes an enucleation or an evisceration. This is also important from a perspective of using that as a baseline to know what could be your implant size. A special informed consent, not just for surgery, not just for anesthesia, but also for enucleation. There is a distinct consent that needs to be taken for that. In case of children who are often the patients in cases of enucleation, I actually take in as many relatives and parents as I can while I take the explain to the patient, the relatives. Also, a video consent may be an important part of your preoperative counseling if you wish to have it. Also, preoperative photograph of the child is extremely important, of the patient, also so that you have a before and after, and also because medical legally it's important to document which is the affected eye. Now, having done that, we come to the technique. Now, the technique that I am explaining is the myoconjunctival technique, the technique that I'm most comfortable with. However, depending on whether you choose a porous implant, you may choose to wrap it, or also a porous implant allows you to do additional procedures later on with the processes like pegging, which although nowadays is less and less frequently done. So this is a short video about the myoconjunctival enucleation technique. Why is it called myoconjunctival? Because once the muscles are cut and disinserted, they are reinserted into the conjunctiva. So the myo or the muscle is reattached to the conjunctiva where it normally would be inserted if the globe had actually been there. So I start the video. The first step I prefer is a lateral canthotomy. A cantholysis is not necessary. Once this is done, a good conjunctival peritomy is done. This is important because in children, the tenons is extremely thick. So what I do next is I use a blunt tipped curved Stevens scissor, and between the two, each of the two recti, you go in, splay open the arms of the scissors such that you create a clean plane of cleavage between the bare sclera or the globe and the tenons. So here you go in and splay open. Once that is done, you use a muscle hook to hook one of the muscles. It can be in any order. Once that is done, you pass a traction suture close to the insertion. This is foro-silk being done. The next thing is to pass another muscle hook that you can see being passed. And then in between the two muscle hooks, I tie a 6/0 vicryl suture through the muscle. Now, this is a tag suture. There is one traction suture and the other is a tag suture. And in between these two sutures, the muscle is then cut. This can be cut after cauterizing or can be directly cut. The 4 recti are thus tagged for traction, and the muscle is also tagged such that you don't lose it later on. Once this is done, you also then have to make sure that the obliques are cut. This is the inferior oblique, and then the superior oblique is also taken care of. And then going in laterally, the important thing is to go in with your blades closed and then strum the optic nerve. The traction sutures that were given here with silk are the ones that are attached to the stumps of the recti muscle, pulling the globe up, making it taut, and making the optic nerve really stretched out. Once you strum the optic nerve in a single bolt cut, you cut the optic nerve and the globe comes out. All the adhesions can be easily cut out later on. Now, once you keep you put hemostasis and put it in for about 4 to 5 minutes, you then take out. Now, here it's important to identify the four edges of the posterior tenons are being held in place, and that is why you have orbital fat within the compartment. Now, this is the intraorbital cavity. Beyond the globe is the orbit. And in this cavity is where the implant goes. So this is the posterior tenons. You can see that the recti muscle here come out from between the tenons and the conjunctiva. So here I'm putting a PMMA or a non-porous implant inside. Once this is done, the posterior tenons are then brought together and sutured together with an absorbable suture like 6 or vicryl, which I prefer. 4 or 5 such interrupted sutures are placed. Now, this is one of the most important layers that needs to be sutured. I prefer to suture the tenons in 2 layers. The posterior tenons is closed, and then here now we take the tag sutures of each of the recti muscle and pass it out through the conjunctiva about 4 or 5 millimeters from the conjunctival edge, hereby attaching the recti muscles into the conjunctiva or the fornix surrounding the globe, such that when the muscles contract, the implant itself will move. Once this is done, the sutures are tied. These are double arm sutures, so they are one passed one after the other. Once that is done, the anterior tenons is closed again with 6-vicryl in interrupted layers. This is the most important barrier that protects against implant exposure or implant extrusion, which is why this has to be meticulously done. Once the anterior tenons is closed, the conjunctiva is then closed in a continuous purse string or a keyhole pattern suture. And once that is done, a large sized conformer is placed. I usually do not bother to reform the canthus because in this case, just a canthotomy was done. A conformer is placed in, you can see a 26 size conformer fits in well, and a suture tarsorrhaphy is done. The eye is patched, and then the patch is taken off the next day with drops being started. The parents and the attendants being explained that the drops has to go through the sides of the central tarsorrhaphy. In certain cases where you have a very small, thin, atrophic globe, which cannot be, in which an evisceration cannot be done, in these cases also you have to do an enucleation. As you can see, this was too small for any of the different techniques like a 4-petal or radial sclerotomy. None of them would have helped in such a small size globe, and therefore we had to do an enucleation, and you can see how small the globe was. So although, when in you read literature, it tells us that when you compare the outcomes, there is a greater degree of enophthalmos seen in patients who've undergone enucleation, and this is because there is greater orbital disruption that occurs during an enucleation as compared to an evisceration, and also because the fornices are not handled much in an evisceration as compared to an enucleation. Now, this is again a child who had a small thicycle atrophic globe, when enucleation was done, and at 6 weeks following enucleation, a prosthesis is created and put in place. These are also acrylic made prostheses that are hand painted to match the other eye. Again, you're able to address the volume and the cosmesis with this. Also, it's a good idea to show patients that you can have good amount of motility with prosthesis. So to understand what happens post surgically. So in enucleations, you have clear indications and clear contraindications. Remember that every eye, every tissue that is taken out from the body has to undergo an histopathological examination. You'd be surprised that sometimes an odd tumor can land up even in an eye in which you didn't expect a tumor. Explain that a prosthesis is going to be given, and prosthesis really helps the patients. Special precautions, especially for in intraocular retinoblastoma, is to make sure you get an extremely long optic nerve stump. So the cut at it, when you go in laterally, the cut at the optic nerve should be at least 10 to 15 mm from the globe, so that you have that much of an optic stump. Try to be as atraumatic as you can to make sure that the sclera is not punctured or there is no accidental globe perforation in these cases. Thank you. And stop sharing my screen.
Fantastic. Very well covered in such a short time. All the basics what I wanted. Very well covered. I think we'll have certain points on our panel discussion. Let's have the second
Sure.
talk.
So,
Uh,
good evening, everybody. I had a technical snag, so I could join only 5 minutes into the meeting. But that was an excellent talk, Akshay. In fact, I missed introducing you. So, I really like how you described the subtleties of the surgery with such crisp precision. And you also highlighted about the procedural and the legal formalities to be completed before this surgery. So, normally, what I have seen is comprehensive ophthalmologists tend to take these socket surgeries a little bit for granted, because for them they feel it's like a lost cause because it's not a seeing eye. But I hope with these videos and presentations, this inspires them, or this meeting galvanizes them into looking at the finer details of these kind of surgeries and rehabilitation as such for the patient. So there are no questions yet in the chat, but maybe a couple of quick points. Would you like to describe to the audience about, any kind of specific anesthesia details, or, prerequisites, or any protocol that you follow for hemostasis other than pressure tamponade?
Right. Actually, that's a very valid point. One important thing is that post in enucleation or even in evisceration, pain can be high. So post-operative pain is something I'll come to, but enucleation is surgery that I strongly recommend that we always do it under general anesthesia. I am not for enucleations under local. Eviscerations, of course, in adults can be done under local. Also, at the time of cutting the optic nerve, 5 minutes before I'm reaching that step, I like to inform the anesthetist such that they increase the dose and they go into a deeper plane that gives us hypotensive anesthesia, such that you don't expect much more bleeding. Another small tip that could be done in cases where you're absolutely certain that there is no intraocular tumor is to give a little bit of retrobulbar block with xylocaine and adrenaline at the beginning of your surgery. That will, of course, will dilate your pupil, but also give a little bit of vasoconstriction in the orbit, such that you have lesser oozing from the fat and possibly from the optic nerve stump when you cut. Again, strongly recommended that you don't do this in intraocular tumors. You just don't want to have that small chance where you could perforate the globe, giving that block. And post-operatively, evisceration patients tend to have more pain. That's because they've had a small globe or a thicycle globe or a smaller sized eye, and now that has been replaced by a large, tense, non-compressible implant, which oftentimes induces a lot of vomiting. So post-operative care, post-operative analgesia and antiemetics are important.
Okay. Thank you.
also, a
Thank you so
point,
much.
also a point I would like to add, Prerna, is regarding tagging of the muscles when you're cutting it. It's better to inform the anesthetist. In this session itself, we had a case where we were doing retinal detachment, me and one of the consultants. And while tagging, the patient had severe arrest. We could not revive him out of it. I distinctly remember. So when you're cutting the muscle or pulling it, it's always better to inform the anesthetist whenever you're doing it, especially when you're given not packing up with a retrobulbar. Anyway,
Right.
point taken.
Yeah.
Go
So
ahead,
since we have ample of time for this discussion, Akshay, me, Namrata, anybody talking in front of Dr. Tarjini would be like preaching in front of the choir. So I really want to have her two bits on, highlighting certain more features about enucleation or what she prefers to do differently in surgeries like these.
Thank you so much, Prerna. So couple of other things that I tend to do in my patients is that when I have the muscle isolated, I sort of like to use the bipolar cautery to cut between the muscle edges. That instantaneously reduces the bleeding and collection in the orbit. Generally, what happens is the muscles tend to slip posteriorly, right? And a bleeding muscle slipping posteriorly is oozing into the orbit. And you're placing the implant into the orbit then gets a little compromised and your suture is very tight. So that's a small pointer of using a bipolar cautery to cut the muscles. There are certain small points which all of us who've trained with Dr. Honavar, Akshay especially, and me, because both of us have this very similar way of operating, and he did point it out, but I want to emphasize again is using the tenotomy scissors towards the orbit while you are dissecting the posterior tenons to free the globe from the rest of the attachments. So the globe has Cournev's septa, which are extensions of intermuscular septa, which are oriented in a 3D plane posteriorly. Separating these septa makes it very easy for you to prolapse the globe out, once you've sort of cut the muscles. So that's another small point. And using your tenotomy scissors posteriorly directed towards the bony orbit rather than the eyeball helps you separate these Cournev's septa by blunt dissection. So probably those are the two other points. Another last small thing, because we touched upon pain, what I do in my practice is I always inject ropivacaine. It's cardioprotective, it's longer acting than both lignocaine and sensacaine. Unfortunately, in India, we don't have Exparel, which is the sensacaine that acts for 48 to 72 hours, which is excellent for post-operative pain control in patients who undergo socket surgery. In the absence of that, using ropivacaine is an excellent stopgap arrangement for you to make it a daycare surgery. Otherwise, these patients need to be admitted for post-operative pain control. So those are the few other points.
What anesthesia do you use, Tarjini? You also go for GA, all cases?
Like Akshay mentioned, when you're going to cut the nerve, it's a sensation that's extremely, difficult to explain, and most patients are not comfortable with it. So for enucleations, I like to use general anesthesia.
That's a sensation that sometimes some patients, extremely perceptive patients, are able to tell you, even in an evisceration, when you have to cut the optic nerve to detach it posteriorly, sometimes you actually end up going posteriorly and handling the nerve. At that time, no matter how much local you've given, the patients still are able to perceive some pain. So GA would be absolute for an enucleation at least.
Dr. Tarjini, I would like to make a point here. Yes, I have tried bupivacaine injecting in all my cases, both evisceration and enucleation. It also works well for for an hour or so post-op. Patients are comfortable, but the pain does catch up. Also, another thing I would like to know from you, which procedure do you feel is maintains the stability of the orbit, whether you feel enucleation versus an evisceration? There's a lot of talk about how dissecting the Cournev's septa and the intermuscular septae is really causing some kind of an instability in the orbit, which later contributes towards my migration of the implant, or the sunken socket syndrome, all those things. Do you really feel that the motility that is offered by evisceration versus the motility that is offered by enucleation, the stability of the implant that is offered by an evisceration versus an enucleation, is it really something that we must consider when we are in a dilemma to go ahead with an enucleation versus an evisceration?
Yeah, Namrata, thank you for the question. So in my practice, in most patients, when I have ruled out an intraocular tumor, either a proven or a suspected tumor, I opt for an evisceration. The surgery is quicker, it's faster, the anatomy is relatively better maintained in an evisceration, and definitely the post-operative motility is better than myoconjunctival enucleation. So I would prefer an evisceration in my patients.
Thank you.
What about the explantation? When does it occur and how do you manage?
I think that is a topic Tarjini will talk about.
Okay.
So we'll still have we'll have some time for questions to catch up. Meanwhile, it's my honor and privilege to introduce our next speaker. So she definitely, before I begin a formal introduction, I think I must say that she, because of her resourcefulness and love for teaching, she's always been a hot favorite with all the fellows and residents that have personally interacted with her. So with this, I'd like to introduce Dr. Tarjini Dave. She's an oculoplastic consultant at LV Prasad Eye Institute. She also heads the ocularistry department very aptly and strongly over there. And with this, she's taken on a new role as the Associate Director of the Kalamanji Reddy campus at LV Prasad, Hyderabad. Now, she basically has a lot of intersection with a lot of anaplastologists, imaging specialists, and I think her ingenuity and surgical skill set is what makes it so unique. She's brought a lot of innovation in India. I remember witnessing it firsthand, in fact, where she, people were speaking about the orbital tissue expander for congenital anophthalmos, or she had done the osseointegrated exenteration prosthesis. And she's done a couple of 3D implants for migrated implants as well as for orbital facial fractures. So Dr. Tarjini also publishes quite a lot, and I don't know how she manages to do all of this in 24 hours in a day. But I'd like to have her discuss about the finer details of evisceration and how we as surgeons can improve on our techniques in this surgery.
Thank you so much, Prerna, for that very, very warm introduction. It's such a pleasure to be with you, Akshay and Amrita, share the stage with you guys. And I'm so delighted to have Dr. Taswala here, who I have seen from my very childhood days.
Yes.
A very fond teacher. So thank you so much, sir, for having me on this podium. I'm hoping my slides are visible.
Yeah, visible.
Right. All right.
Very clear. Voice is also clear.
Right. Thank you. So I'll take you through evisceration and implant. I don't have any financial disclosures to make. And I've sort of labeled it as oops, because I'm going to sort of tell you the technique as well as the difficulties that one is likely to face. So on the right-hand side of your screen are the points along which I'm going to discuss my presentation. All right. So this is the first part of my presentation where we're going to have a little bit on indications. Akshay very aptly covered the entire spectrum of indications. So I just wanted to divide you to have your attention on the left side of the slide where you see this collage of 4 eyes. All of these are either disfigured or painful blind eye or an eye with staphyloma. And necessarily in any such end-stage eye disease, you need to perform a B scan to rule out an intraocular tumor that might be lurking somewhere inside. Once you have ruled out an intraocular tumor, by whatever imaging modality that you'd want to, with the history combined, for these kind of end-stage blind eyes, you go ahead and perform an evisceration. However, when you have a known or a suspected intraocular tumor, as you're seeing here on your right-hand side, a leukocoria with a mass lurking behind the iris, or a B scan picks up a tumor in the eye, in this case, you're suspecting a melanoma in the B scan, then these are cases where evisceration is an absolute contraindication. Let me look at... just one moment. I'll just share the surgery video separately since it's not coming up here. Prerna, just let me know if it's playing.
Yeah, it's coming.
It's here, right? Yeah. So I'm just going to take you through the surgical steps. So as you can see over here, this is, it's playing, right, sir?
Yes.
Yeah.
A retrobulbar block that I have given to this patient. I like to inject a little bit of subconjunctival lidocaine with a little bit of adrenaline to get some hemostasis. And then you begin by performing your standard 360-degree peritomy around the limbus. Now, the conjunctiva is the most important tissue, and you want to save as much conjunctiva as you can. This is the second step where you're going in the 4 oblique quadrants to actually dissect the posterior tenons from the globe. You then make a stab incision and dissect off the corneal button at the limbus, making sure not to give pressure on the globe to prematurely prolapse the contents. Now, this is an instrument which is known as a periosteum elevator and works much better than using an evisceration scoop in actually dissecting off all the uveal tissue from the sclera. And you do that all 360 degrees and then scoop out the contents. You'll have some bleeders that can be cauterized by either a bipolar or a monopolar cautery. What I'm now doing is using alcohol to clean off the scleral cavity, and then the alcohol is washed off. Alcohol is very corrosive, so you need to wash it off, otherwise you'll have inflammation. Now, this is an important step. This is where sclerotomies are made or petals are made. So we've gone from the limbus posteriorly, and 3 millimeters from the optic nerve posteriorly, we are dissecting off the sclera. So essentially what it has done is you now have these two scleral flaps which are free to move anteriorly. And within these two flaps, you insert your implant. We've placed a 20 millimeter implant over here. Now, since these scleral flaps are suspended by extraocular muscles, but posteriorly are dissected off from the optic nerve, they're free to move anteriorly and give you a tension-free closure. So this is the scleral closure. Closure is typically done in 3 layers. First is the sclera, second is the tenons, and third is the conjunctiva. Now, this is the tenons, the anterior tenons, which is being closed with the help of 6-0 interrupted sutures. The same suture was used to close the sclera. And finally, we are closing the conjunctiva with the same 6-0 suture, but in a running fashion. So this is the 3-layer closure that you would perform in any evisceration. The importance of this kind of conjunctival closure is the edge is everted and cysts do not form, retention cysts do not form. This is the ropivacaine injected at the end. And this is what I wanted to sort of tell you, that when you make the flaps, what you've done is that part of sclera is suspended by the extraocular muscle, but it is dissected off from the optic nerve. So that scleral flap is very mobile to now come anteriorly and give you a tension-free closure, which is the most important factor in avoiding implant extrusion in socket surgeries. Now, you could also use a porous implant as is being used over here, but when you're using a porous implant, you need that blue introducer because the surface of the implant is rough. If you do not use the introducer, you're going to have post-operative complications such as exposure of the porous implant. So just a view again at that. This is the introducer which comes with the implant, which is used to push in the implant within the scleral flaps.
Thank you so much, Dr. Tarjini, for this excellent video presentation. Now, since you've also shown us about the porous polyethylene and, the porous polyethylene implant and how it needs to be introduced, as oculoplasty surgeons, I think we often face these questions from comprehensive colleagues where they want to know what is the ideal implant as far as socket surgeries are concerned. So there are definite risks and benefits of each kind of implant. But out of your years of experience, is there some point you want to highlight over your preference or choice of implant for socket surgeries?
Right. So I typically prefer to use in most of my eviscerations a porous implant. The reason for that is it is a biointegrable implant. The porous implant just by itself is not going to give you better motility of the prosthesis. However, since it gets integrated with the orbital tissues, the other complications such as migration and extrusion of the implant are much less when you use a porous implant. The disadvantage of a porous implant is the cost that is involved in in purchasing the implant. So it's about 8,000 to 9,000 rupees versus your PMMA implant, which you can get for about 150 rupees. So that's the disadvantage. So the most important side effect in a porous implant is exposure because of its rough surface, which can be avoided if the surgical technique is good. The non-porous implants come with the side effects of or the complications of exposure, extrusion, or migration.
Sure. With this, anybody else from the panel would like to highlight on how ideally we would size the implant and, what are we looking at? What kind of volume replacement are we looking at in terms of with the implant and in terms of with the COP? So Akshay, would you like to take this point of discussion?
Yeah, I think there are different techniques, and like you said, there are no one technique that is right as long as you're not undersizing the implant. There are people who prefer to measure the contralateral normal eye and then allow for that. We have formulae where you add 2 millimeters of the axial length of the other eye, or reduce 2 millimeters of axial length of the other eye to allow for the prosthesis. You can even use an active sizer like you mentioned. Typically, I make sure that my implants are no lesser than at least an 18 or a 20 implant. Anything less than that is as good as keeping the patient anophthalmic, because a 16 implant really doesn't add any volume to the orbit, and you end up having to compensate with a large, heavy prosthesis instead.
Correct. So I remember Dr. Tarjani would lay a lot of emphasis on maybe about 70% of the orbital volume replacement by the spherical implant. And I remember she would say that maybe the additional 25-30% comes from the customized ocular prosthesis. Now, maybe she will be a better person to highlight that. But what I want the colleagues to take forward from this is there are innumerable complications that arise because of smaller sized implants. So Dr. Tarjani has also done volumetric analysis, and she has a better idea to discuss about complications like post-enucleation socket syndrome and lack of volume and support. So any additional points you would like to add for as far as the volume is concerned, Dr. Tarjani?
Yeah, so Prerna, 70% of the volume, like you rightly mentioned, is what should come from your implant. And the remaining 30% should come from the prosthesis. Now, if you look at an adult average axial length in Asians or Indians, then it's going to be somewhere around 23, 24, right? So 23, say. So 70% of that would mean that you actually put an implant which is about 20 millimeters in diameter. So that's an absolute must. So when you're actually putting 16 and 17 millimeter implants, you are not really doing justice. Another important point here to remember is between 16 to 17, the change in volume is not the same as the change in volume between 19 and 20. Right? Because the change in volume is exponential, because that 1 millimeter is all around. So every millimeter here matters, and that sort of helps you get a very good volumetric outcome in a lot of patients. So I'll just show you a couple of images. Say, for example, this lady over here who has, a very tiny implant in the socket, and because of that, the prosthesis is very large. And look at the lower eyelid. The lower eyelid is bearing the brunt of the weight of the prosthesis because there's no volume inside the orbit. So when you place an implant inside her socket, immediately the lower eyelid comes back in position. Yes, she has a little bit of ptosis that can always be corrected later on, but that addition of volume helps bringing the lower eyelid back in place and also helps making the sulcus fuller. So this is the sulcus. Compare this deep sulcus pre-operatively to the fuller sulcus post-operatively, because you've added volume where it rightly belongs. When you remove the eye, you need to add the volume in the orbit. You cannot be adding volume just in the prosthesis. If you use a smaller implant, prosthesis is going to be that much larger. So these are all patients like another gentleman here who has an excellent prosthetic outcome, but is very bothered by the sulcus. This minimal amount of enophthalmos of the prosthetic eye is because the implant was a tad bit smaller than what it had to be. So these are patients like this gentleman has undergone a filler injection, and you can see that the sulcus immediately builds up the minute you've injected the filler. You see that small mark in the skin over here through which the filler has been injected. And you also see a correction in the enophthalmos in these patients. So that's very important when you're having a volumetric consideration to the outcome of socket surgery.
So any comments or questions? We have a lot of people who've joined us, including from the MOS committee. Any comments or questions from our colleagues?
How do you do volumetric analysis, Tarjani?
Right, sir. So pre-operatively, you mean before planning the surgery?
Yes, yes.
Typically, you should, like I mentioned, if you go by the benchmark of a 20 millimeter implant, it will suffice in most Indian eyes. There are certain exceptions to that situation. Those exceptions are patients who have a staphylomatous eye to begin with, because the eyeball is large, the orbit also enlarges. So there you might need to use a larger implant, say a 22 millimeter implant, or a socket which also has an orbital fracture. So again, there the volume of the orbit is expanded and you may need to use a larger implant. But otherwise, if you want to have a formula, then like Akshay mentioned, you can subtract 2 millimeters from the axial length of the normal eye. And that will give you the diameter of the implant that you should place.
What about thusical eyes where the socket is contracted? How do you manage that?
So that's exactly the situation where you perform the petal technique that I showed you, where you are dividing the sclera into those flaps or petals. So even if the sclera is small, it gives you enough movement of those flaps of the sclera to come anteriorly and close the implant. So even if it's a very thusical eye, you could still go ahead and perform an evisceration.
Tarjini, I had one question. In the gentleman whom you had the filler, was that that was a deep retrobulbar filler on the inferolateral aspect, or just deep into the intraconal?
Akshay, I like to inject it behind the implant.
Okay, so intraconal time.
Bulbar block. So I like to go transconjunctival, and I go exactly like how you would give a retrobulbar block. You know, like a good block is when you're seeing proptosis on table.
Right.
So that's
right.
Exactly what I do. So I take a 24 gauge needle and I use a cohesive filler, something like a volumer, to sort of act as a second blob of implant behind the existing implant and push it forwards.
How do you manage the extrusions, Tarjini?
So that's the question that you had asked, and for that I was trying to play this video. So I'm hoping it's playing for you as well. This is
it's playing. It's playing.
Yeah, this is an extrusion of a PMMA implant with a lot of perforations within the sclera. So what you do is you go ahead, you remove that implant, you dissect the rest of the sclera from the tenons and the conjunctiva. You can excise the unhealthy sclera. Like I told you, you don't need to have really large flaps of sclera. So you excise all the unhealthy sclera, and you make a couple of, posterior incisions circumferentially around the optic nerve to release the rest of the flaps that you have. You also remove all the peri-implant capsules which are adherent to the sclera, because these capsules have macrophages which push the implant out. So after you've done that, you replace another new implant. This is unhealthy sclera being excised, and then you close. So you don't really need to do a lot in terms of chopping off the entire sclera in patients who have implant extrusion. Just remove the unhealthy part and then close the rest of the sclera.
But is it the same size implant that you're putting, or you're changing the brand also as a porous one so it doesn't explant?
Well, you can consider placing a porous implant, but you don't need to change the size of the implant. You don't need to undersize the implant just because you have exposure. When you've had an exposure, you'll realize that posteriorly, whatever flaps of the sclera you had made are probably fused again. So you might need to separate those flaps again, make them mobile and let them come anteriorly and give you a good coverage. Certain times you might have little surface loss because conjunctiva also gets excised. In those situations, it's good to harvest a mucous membrane graft from the lip and give a closure rather than pushing the conjunctiva, to give closure. Yeah. When you bring the two edges of the conjunctiva forcefully together, you're shortening the fornicis. So you do not have a good outcome of the prosthesis.
What about posterior staphyloma? What is the indication for enucleation and evisceration in such cases? What do you opt for? And how do you manage? Especially as Akshay said, we do a B scan, so definitely it shows a big posterior staphyloma. And you have this case indication of enucleation and evisceration. What do you opt for and why?
As long as there is no tumor in an eye with posterior staphyloma, I go ahead with an evisceration. Any eye where there is a suspected or proven intraocular tumor, I go ahead with an enucleation. Other than that, everything else is an evisceration.
And the size of the implant,
and also in a posterior staphyloma? In an eye with a posterior staphyloma, it's likely to be a myopic eye, long axial length. You should have, although little thin, but adequate scleral flaps. So, large size implant for sure.
So I would look at, you were asking about the size of the implant. So I would look at whether the orbit is expanded in these patients, you could just simply do a CT scan preoperatively. If you look at the coronal cuts on the two sides, you'll make out if there is macroorbitism or if the orbit has enlarged because of a larger eyeball. If that is there, you place a larger implant. If that's not there, you go with the standard implant as we discussed.
Great.
There is a very specific question by Dr. Manoj Saswade. This is, I'm streaming through a live presentation on YouTube. This is for Akshay. So do you suture the posterior tenons first and then put the implant in the pouch and then suture anterior tenons and conjunctiva with muscles to prevent migration of implant into the orbit, is what I'm assuming. Akshay, would you like to take that?
So, yeah, I think the aim is to put the socket in the space posterior to posterior tenons. In that space is where the orbital fat is, and that you can identify that space, which is bound by the posterior tenons on all sides. So you have to put the implant first and then close the posterior tenons. And after the posterior tenons is closed, you then pass the myoconjunctival sutures from the muscle tips into the conjunctival fornices and then the anterior tenons. So in that order.
So that answers Dr. Manoj's question. Basically, you have to put the implant in the intraconal space. That in fact will have lesser chance of migration than sandwiching it between the posterior part of tenons and the anterior tenons. So the second question he has is, he's done an enucleation in a 2-month-old child with retinoblastoma stage 5. I couldn't implant silicone prosthesis on table. Will you highlight how to enhance normal orbital growth? So this is a very common case scenario. I think we can have a discussion about this in itself. And maybe we start off with Akshay, since it's directed at you, and then we can see what Tarjini has to say about this.
Somebody's phone is ringing. Tarjini, you start the discussion.
No, Akshay is starting, sir. I'll follow Akshay.
Okay.
I think no, I'd be happy if she goes on. But yeah, just to add my 2 cents is, the ideal, rightly pointed that you want to maintain good orbital growth. The presence of a globe and even the presence of a globe-like structure, even a thicical eye, even an anophthalmic eye in an orbit is the stimulus for that orbit and that side of the hemiface. Then the cheek, the maxilla, the orbital bones, the orbital cavity, all of that derive their stimulus for growth from the presence of a globe in the socket. So it's extremely important that we fill that socket up with an implant. So my first go would be to allow the initial insult of surgery to heal and perhaps plan a secondary implant as soon as possible. Children who are probably at 4 to 6 months old would be definitely old enough and healthy enough to undergo anesthesia and then undergo a secondary implant. In this patient who's recently undergone an enucleation, a secondary implant, either a porous or a PMMA, I would prefer, because that's my experience with it, a PMMA implant, a large-sized implant. As once the orbit has healed, you go in and do a secondary implant. This is not a case where I would plan serial orbital expanders, because the option of a secondary implant is very, very feasible to do in this child. So that would be my advice. But in children, especially if you have parents who are not convinced to have their child undergo a surgery early, letting them know that having a large implant gives that much stimulus for the craniofacial development is important. Tarjini, would you also align on putting a secondary implant ASAP?
Yeah, so Akshay, as I understood, Prerna said it's a 2-year-old child. So just a few other concepts.
I heard 2 months.
2 months.
I heard 2 months.
Oh, okay, 2 months. So yes, I would absolutely agree with Akshay. Certain other things which are minimally invasive are, and this is again controversial, but it's very useful, is just injecting a blob of filler in the socket. So it's minimally invasive, and it also acts as a volume agent, which helps you in the growth of the, like Akshay said, you only need stimulus, whether it's a or a small blob of filler, you just need some amount of stimulus for that orbit to grow. And as soon as the child is fit for anesthesia, I would take up the child and place an implant. Again, like Akshay said, I would in this situation go for a silicone implant or a PMMA implant, because in future you might need to exchange it to a larger sized implant. When you want to perform an implant exchange, a silicone is much easier to exchange.
How do you size the implant in such cases? 2-month-old?
Children that are less than 1 year of age and you're performing the surgery, you typically have an implant which is about 16 millimeters to 17 millimeters in size that you're placing. And a child that is more than 1 year of age, you should try to place an 18 millimeter implant. By 2 years of age, the orbit attains 95% of its growth. And by 5 years of age, the orbit is adult size.
So when do you go for the serial surgery in case you plan to exchange the implant? After a year, after 2 years of this thing, or after 5 years of it?
Usually, I would prefer to operate around 4 to 5 years, preschool age, when the child is going to be more conscious. At that, if there is an implant already inside an exchange, I would plan around 4 to 5 years of age. If there is no implant inside, then implant placement, I would plan as soon as GA is possible.
Good. Very nicely answered.
So, Dr. Tarjini, can you tell us about the longevity of the filler in the orbit in terms of, is it any different from how long it lasts on the face or around the muscles of the face?
So orbital fillers probably last slightly longer than the periocular fillers, and typically you would have its effect for about a year.
Okay.
So at that point of time, you might need to consider replacing. Yeah.
So the filler should be put immediately post the way the Manoj Sasavadi asked you at 2 months. If you're not able to put an orbital implant, temporarily you put the filler right away that time only, and review of once the child is for GA ready. That is what you say?
You could do that, sir. It's just an option. If you don't do, I mean, you obviously are doing enucleation in a 2-month-old child under GX. So, I mean, since it is already under general anesthesia, primary implant placement is always the best thing to go ahead with. Even in a 2-month-old child, whatever you can place inside a 14 millimeter or, whatever size goes in, you should do that.
Initially itself.
Yes.
No, he could not do it. That is why he asked for a different testing expanders.
The reason for that could be probably intraoperative hematoma or something like that, that is not allowing you to place an implant. In that situation, I would not even inject a filler. The blood itself is acting as a, expansion sort of a stimulus. So as soon as the hematoma absorbs, then I would plan the child for, something like a delayed implant placement.
Yeah.
So I think
just one thing is that whenever you inject a filler, make sure the block or anything that you give does not have hyalase in it, because hyalase or hyaluronidase will dissolve your hyaluronic acid filler. So
Okay.
So basically, I think take-home message, let's not confuse with so many questions about this, would probably be, since it's a small kid, you would probably need some form of sedation GA even for the filler. So what I understand the panel is trying to mention here is a secondary implant will top a filler injection, but in case that is not possible or feasible or the preferred choice by the parents, then you can think of a substitute like a filler.
Quite right. So, any more questions, Prerna, on the YouTube page? Just check before we sign off.
So this is about it on YouTube and Facebook. These are the questions that we've got. Have we got anything on the chat here? No.
Nothing.
Prerna is having computer vision syndrome. She's been moderating webinars from 6 p.m. onwards.
Actually,
okay, Prerna.
But I really like how we've discussed this topic, because what I feel is, even amongst oculoplasty surgeries, there are surgeries people take more fancy to, but these are some of the real basic problems we encounter. And these are really some of the questions we face from our colleagues or even from parents. So I'm pretty happy we've cleared a lot of doubts over here.
Absolutely. So, and a concluding remark, a big thank you to all the panelists who are very much here. and he really enlightened us on the topic, the basic topic, as Prerna rightly said. It's so well covered. It's going to really help the general ophthalmologist. And of course, this gold standards that you have set is going to go a long way helping the freshers and the postgraduates and the fellows in a big way. Thank you, Dr. Akshay and Dr. Tarjani, Dr. Namrata, of course, she left for reasons, and Dr. Prerna. Very nice moderation and very nice, lively discussion on this topic, which I had close to my heart and was very well covered. Thank you to the Enboard people also, the audience who have joined on the Facebook and the YouTube and the webcast. And of course, my close friend, Dr. Rajesh Joshi, who is the secretary, who is going to give us the vote of thanks. Before that, we have a gallery view photograph. Keep the video on mode. So we have that for our nostalgia. And of course, following that, the Enboard people would like to play a video. They have been there as a strong backup, always technical backup. And after that, vote of thanks by Dr. Rajesh Joshi. Yes, Sayyad, can we have a gallery view photograph? The video. The youngsters have really led the show very nicely. As Sarjani, I remember we had been to the, I think, Mauritius. You were there. She was so young. I would see her, and now she's matured and grown up and become the. We are so proud of you, Rajini. I'm absolutely thrilled the way you discussed it out, and of course Akshay and Prerna also, and Namrata. The young bandwagon is really pulling the show way high, and of course the standards are also very high, well set. And your techniques, whatever you're coming up, you're catching up with it, and of course implementing in letter and spirit. That's good. So, gallery view photograph and then vote of thanks. Sayyad?
Yes, done, sir.
Ashwin?
Yes, done, sir.
Yeah. So, thank you, a big thank you once more. Rajesh, over to you for a proper vote of thanks for each
Yeah.
of them who have taken time out for us,
Yeah.
the leaders in oculoplasty. And this is the first of the series which Akshay, Tarjani, Namrata, and Prerna have started. We'll be going forward later on.
Yeah.
So, over to you.
That was the perfect teaching webinar on these two procedures. On behalf of MOS, I thank Dr. Tarjani and Dr. Akshay for highlighting various aspects of evisceration and enucleation practice. Both the talks were to the point and useful to all the postgraduates, fellows, and general practitioners. Thank you, Madam and Dr. Akshay, for sparing your valuable time. Thank you, Dr. Prerna, Dr. Namrata, for agreeing to be panelists and giving valuable inputs. Thanks, Dr. Prerna, for conducting the session so well. I'm also thankful to all those who have joined on the virtual platform for today's webinar. Thanks to Entor for the technical support. Thank you all and good night.
Thank you. Thank you, everyone.
After
Thank you so
recording,
much.
yes, so we can have an informal discussion.
So just a moment, sir. I'll do it.
Yeah. Can we have the head count on the YouTube and this so we know?